Atopic dermatitis, or atopic eczema, is a skin rash that's particularly common among young children, but can last into adulthood. Atopic refers to an allergy, derm refers to the skin, and itis refers to inflammation. So, atopic dermatitis describes skin inflammation that results from an allergy. More specifically, it happens when the immune system attacks the skin, causing a dry, itchy rash on flexor surfaces of the body, areas like the creases of the wrist, the insides of the elbows, and the backs of the knees, as well as exposed skin surfaces like on the face, the hands, and the feet. When the immune system inappropriately starts attacking itself, we call that a hypersensitivity reaction, and there are 4 types. Atopic dermatitis is a type 1 hypersensitivity reaction, and it starts off with something in the environment called an allergen, like flower pollen. The pollen's able to travel through the slightly porous skin, where it gets picked up by an immune cell in the tissue just below. The immune cell is called an antigen-presenting cell because it presents a bit of the allergen to a naive T helper cell, activating it into a Th2 cell. This Th2 cell then stimulates a nearby B cell to start producing IgE, or immunoglobulin E antibodies specific to that pollen. Those IgE antibodies bind to the surface of other immune cells, called mast cells, as well as basophils, which can be found in the tissue layer just below the skin. And this process is called sensitization. Now let's say there's a second exposure to pollen that makes its way into the skin tissue. Now the allergen can cross-link the IgE on these sensitized cells, resulting in degranulation or release of a number of pro-inflammatory molecules like histamine, leukotrienes, and proteases. The combined effect of these molecules is to cause nearby blood vessels to dilate and become leaky, as well as attract even more immune cells to the area, creating inflammation of the skin tissue. Ultimately, this inflammation makes the skin barrier more leaky, potentially allowing in more of the allergen, while at the same time allowing water to escape, leaving the skin dry and scaly. Dry skin's very itchy, and scratching further damages the skin barrier, worsening the process and setting up a vicious cycle of allergy-mediated inflammation, dry skin, and itching, which characterizes atopic dermatitis. Occasionally, bacteria can invade the damaged skin, causing even more inflammation. In infants, the rash is most often on the face and the scalp, and in children, the rash is usually on the flexor surfaces of the extremities. Atopic dermatitis can worsen in the presence of allergens like cigarette smoke, mold, and dust mites, as well as changes in the weather, and even emotional stress. Although it usually causes patches of red, itchy skin that come and go, the skin can occasionally even blister and peel. Over time, the skin can become lichenified, which literally means turn to leather. Itchiness is often worst at night, probably because there are no distractions, and this is often when young children are most likely to scratch their eczema lesions. Because eczema is an autoimmune mediated process, it can't be spread to other people. But since it affects the skin and therefore the way a person looks, there's still a lot of social stigma associated with it. Unfortunately, many individuals, especially teenagers and young adults with atopic dermatitis, suffer from depression and social anxiety as a result. Genetics plays an important role in atopic dermatitis, and these individuals often also have asthma, as well as allergic rhinitis, making up what's called the atopic triad. These illnesses also often run in families. Occasionally, atopic dermatitis can be part of a syndrome, like hyper-IgE syndrome, which has an autosomal dominant form called Job syndrome, as well as phenylketonuria, which is a metabolic disorder that results from the buildup of the amino acid phenylalanine, and Wiskott-Aldrich syndrome, which is an X-linked recessive disease characterized by a clinical triad of eczema, thrombocytopenia, and immunodeficiency. Atopic dermatitis is generally a clinical diagnosis, and there are ways to help break the cycle of allergy-mediated inflammation, dry skin, and itching. With regard to allergy-mediated inflammation, it's important to identify and avoid any triggers, as well as avoiding overheating, dressing in soft fabrics, and managing stress well, which is, of course, a good life habit, anyways. Dry skin can be managed with frequent moisturization, which is usually best to apply after a lukewarm bath. And itching can sometimes be managed with simple measures, like keeping the fingernails short and trying to keep children from scratching. But in more extreme cases, there are also steroids and calcineurin inhibitors, both of which aim to dampen the immune reaction, as well as antihistamines that can help with itching, and antibiotics to help treat infections if they're needed. Alright, as a quick recap, atopic dermatitis, also known as atopic eczema, is a type 1 hypersensitivity reaction in the skin, and is characterized by a cycle of allergy mediated inflammation, dry skin, and itching that most commonly affects infants and young children. Atopic dermatitis can be managed by minimizing exposure to allergens, keeping the skin hydrated, and minimizing itching.
With lichen planus, lichen means tree moss, and planus refers to flat. And the reason it's called that is because lichen planus is a flat topped skin rash that looks a bit like tree moss. Lichen planus is an immune mediated disorder, meaning that the immune system has started attacking its own skin, resulting in the rash. Lichen planus can also affect mucous membranes. Now, the skin is divided into three layers. The epidermis forms the thin outermost layer of skin. Underneath is the thicker dermis layer that contains the nerves and blood vessels. And finally, there's the hypodermis, which is made of fat and connective tissue that anchors the skin to the underlying muscle. The epidermis itself is made of multiple layers of developing keratinocytes, which are flat, pancake shaped cells that are named for the keratin protein that they're filled with. Keratinocytes start their life at the lowest layer of the epidermis, called the stratum basale, or basal layer, which is made of a single layer of stem cells that continually divides and produces new keratinocytes. These new keratinocytes then migrate upwards to form the other layers of the epidermis. The stratum basale also contains another group of cells, the melanocytes, which secrete a protein pigment, or coloring substance, called melanin. As keratinocytes in the stratum basale mature and lose the ability to divide, they migrate into the next layer called the stratum spinosum, which is about 8 to 10 cell layers thick. The next layer up is the stratum granulosum, which is 3 to 5 cell layers thick. Keratinocytes in this layer begin the process of keratinization, which is the process where the keratinocytes flatten out and die. Keratinization leads to development of the stratum lucidum layer, which is 2 to 3 cell layers thick of translucent, dead keratinocytes. Finally, there's the stratum corneum, or the uppermost and thickest layer of the epidermis, which is like a wall of 20 to 30 layers, where the glycolipid acts like the cement and the dead keratinized cells are the bricks. Now, the part of the skin connecting the stratum basale of the epidermis to the underlying dermis is called the dermoepidermal junction. In healthy people, this junction looks like smooth waves between the epidermis and the dermis. But if you look closely at this junction, there are two parts. The first part is the lower portion of the plasma membrane of the keratinocytes in the stratum basale, which contains glue-like substances called hemidesmosomes. These hemidesmosomes adhere keratinocytes of the stratum basale to the second component of this junction, which is called the basal lamina. The basal lamina contains a group of molecules that provide structural and biochemical support to the keratinocytes. Typically, when a cell becomes infected with viruses or mutated by cancer, antigens from inside the cell will be presented on MHC1 molecules, which are found on all nucleated cells in the body. If this were to happen, then a specific cell of the immune system, called a cytotoxic T cell, would use its receptor to bind to the MHC class I molecule, which would cause it to release its payload of perforin and granzymes. Perforin would perforate the target cell by forming pores, and these pores would allow the granzymes to enter into the cell. Once inside, the granzymes would induce apoptosis, or programmed cell death. In lichen planus, some healthy, non-infected keratinocytes start presenting antigens on MHC1 molecules, and it's unclear why they do that. This antigen presentation on MHC1 molecules enables cytotoxic T cells to attack these keratinocytes and kill them. In killing the keratinocytes, these cytotoxic T cells also release cytokines, which recruit more cytotoxic T cells to the scene. That leads to more damage to the keratinocytes, as well as to the surrounding tissue in the basal lamina. That changes the shape of the dermo-epidermal junction. It goes from looking like smooth waves to being more angulated and sawtooth-shaped. Also, melanocytes at the stratum basale become damaged, and they release their melanin, causing the skin to become darker or hyperpigmented. Over time, the damage caused by cytotoxic T cells extends beyond the stratum basale and the stratum spinosum and reaches the stratum granulosum. Keratinocytes in the stratum granulosum respond by increasing in both number and size, which causes the stratum granulosum to become thicker, and this is called hypergranulosis. Now, in some cases, this process gets triggered by a specific medication, like anti-malarial medication. And if a cause is identified, then it's called lichenoid reaction, rather than lichen planus. Now, symptoms of lichen planus mainly depend on the site of inflammation. If it happens in the skin, nails, or hair, then it's called cutaneous lichen planus, and it often affects the wrists and elbows. And if it occurs in the oral mucosa, then it's called oral lichen planus. Most of the time, cutaneous lichen planus and oral lichen planus are both present at the same time. An oral lichen planus typically affects individuals between ages 45 and 65. Lichen planus can be described using the 6 Ps. The first P is for planar, meaning that the rash is flat-topped. The next P is for polygonal, which means that the rash has multiple sides. The next P depends on the diameter of the skin rash. If it's less than 5 millimeters in diameter, it's called papular, but if it's more than 5 millimeters, it's called a plaque. The next P is for the purple color of the skin rash. And the final P is for pruritic, meaning that it's itchy. Sometimes the surface of oral lesions are covered with white, reticular, or net-like lines called Wickham's striae. In fact, that's the most common feature in oral lichen planus. The diagnosis of lichen planus is based on its appearance and can be confirmed with a biopsy that shows a sawtooth-shaped dermo-epidermal junction and a thickened stratum granulosum, or hypergranulosis. The treatment of lichen planus is geared at suppressing the immune system with corticosteroids. In a lichenoid reaction, the trigger is known, so that trigger is removed. Alright, as a quick recap, lichen planus is an immune-mediated disorder in which keratinocytes in the stratum basale of the skin, or mucous membranes, are attacked. Individuals with the cutaneous form have a skin rash, while people with the mucosal form often have white papules covered by Wickham's striae. Diagnosis can be confirmed with a biopsy that shows a sawtooth-shaped dermo-epidermal junction and a thickened stratum granulosum, or hypergranulosis. Treatment includes corticosteroids.
Psoriasis is a non-contagious, chronic autoimmune disease that causes skin inflammation, and is linked to other autoimmune deficiencies such as psoriatic arthritis. It can be incredibly itchy and form silver plaques on the skin that can be embarrassing. Afflicted reality TV star Kim Kardashian and singer Cyndi Lauper have each spoken out about how psoriasis can have a significantly negative impact on the quality of life. Normally, the skin is divided into 3 layers: the epidermis, dermis, and hypodermis. The hypodermis is made of fat and connective tissue that anchors the skin to the underlying muscle. Just above the hypodermis is the dermis, which contains nerves, sweat glands, lymph, and blood vessels. And just above the dermis is the epidermis. The epidermis itself has multiple skin layers that are composed of developing keratinocytes, which are named for the keratin protein that they're filled with. Keratin is a strong, fibrous protein that allows keratinocytes to protect themselves from getting destroyed when you rub your hands through the sand at the beach. Keratinocytes start their life at the lowest layer of the epidermis, called the stratum basale, or basal layer, which is made of a single layer of small cuboidal to low columnar stem cells that continually divide and produce new keratinocytes. These new keratinocytes then migrate upwards, forming the other layers of the epidermis. As keratinocytes in the stratum basale begin to mature and lose the ability to divide, they migrate into the next layer, called the stratum spinosum, which is about 8 to 10 cell layers thick. The stratum spinosum also has dendritic cells lurking around, which are star-shaped immune cells constantly patrolling for invading microbes as part of the body's immune defense system. The next layer up is the stratum granulosum, which is 3 to 5 cell layers thick. Keratinocytes in this layer begin the process of keratinization, which is the process where the keratinocytes flatten out, get rid of their intracellular structures, and die, and in the process they create the epidermal skin barrier. Keratinization leads to the development of the stratum lucidum layer, which is 2 to 3 cell layers thick, of translucent dead keratinocytes that have shed nuclei. The stratum lucidum is only found in thick skin, like on the palms and soles of the feet, because those are the areas that need extra protection. The stratum lucidum is absent in thin skin, which covers the rest of the body, and the other layers are thinner. Finally, there's the stratum corneum, or the uppermost and thickest layer of the epidermis, which is like a wall of 20 to 30 layers. As new keratinocytes push up into the stratum corneum, older dead cells are sloughed off, forming skin flakes or dandruff. In this way, the thickness of the epithelium remains constant with a regulated turnover of keratinocytes. Normally, there are microbes that live on the surface of the skin, but when there's a tiny break in the skin or cut, those microbes have the ability to enter into the skin layer. At that point, the body notices these foreign invaders, and immune cells, called dendritic cells, capture the foreign antigens, break them down into little fragments that they then present to T cells. There are 2 different types of T cells: cytotoxic T cells, which directly kill infected cells, and helper T cells, that help to facilitate the overall immune response. So if the dendritic cells present these fragments, and the fragments are recognized by the T cell, then the T cell releases cytokines. Cytokines are small proteins used in cell signaling, such as IL-12, IL-23, interferon gamma, tumor necrosis factor, or TNF, and IL-17, which specifically has been linked to chronic inflammation. This entire process of inflammation increases keratinocyte proliferation in the skin. This also recruits other immune cells like neutrophils to the site of infection. Once the microbe is completely destroyed, the immunological response slowly returns back to normal. In psoriasis, this immunologic response leads to excessive inflammation. The causes of psoriasis aren't clear, but there seems to be a genetic component because the condition seems to run in families. In addition, there may also be an environmental trigger, like trauma or a previous infection. Regardless of how the process is triggered, once it's underway, it doesn't shut off, resulting in chronic damage to the skin. In the dermis, inflammation causes the blood vessels to dilate, particularly at the border between the dermis and epidermis. That delivers more immune cells, particularly neutrophils, to the epidermis. In the epidermis, the neutrophils collect in the stratum corneum layer. The inflammation also causes keratinocytes to proliferate excessively and mature abnormally. The increased keratinocyte proliferation thins out the stratum basale, but thickens the other layers, particularly the stratum corneum and stratum spinosum. In fact, as keratinocyte growth outpaces sloughing off, the cells begin to pile up. These proliferating keratinocytes have a few maturation defects, which are most obvious in the stratum corneum. First, the keratinocytes produce more keratin than usual, causing this layer to become even thicker. Second, the keratinocytes retain their nuclei, which is called parakeratosis. Third, the keratinocytes do not adhere to each other properly, causing breaks in the epidermis and giving the skin a scaly appearance. If scales are picked off, the blood vessels in the dermis can get injured, causing localized spots of bleeding, called an Auspitz sign. Symptoms of psoriasis can vary, and there are a few subtypes. Plaque psoriasis is the most common. It appears as flattened areas of epidermal elevation that are inflamed and red or salmon-colored from the underlying dilated blood vessels, and they're topped with white silvery scales. Plaques are typically itchy and found on the scalp and in tensor regions like the elbows, groin, lower back, and knees. Guttate psoriasis appears as small, red, individual spots on the trunk and limbs. This subset usually starts in childhood and is sometimes triggered by an infection, like strep throat. Inverse psoriasis appears as smooth and shiny red lesions that lack scales and typically form within skin folds, like in the genital region, underarms, or under the breasts. Pustular psoriasis appears as areas of red skin with small, white elevations of cloudy pus, formed from dead immune cells. They are usually tender and form on the hands and feet. And erythrodermic psoriasis appears as fire-red scales that can cover any large area of the skin. They are often extremely itchy and painful and fall off in large sheets. Psoriatic arthritis manifests as inflammation in the joints. Nail pitting, shallow or deep holes in the nails, may appear in any subset. The diagnosis is typically based on the distribution of the skin damage, and a tissue biopsy can be done to confirm the diagnosis by looking for classic changes in the epidermal layers. Treatment for psoriasis can include moisturizers and emollients to help clear psoriatic plaques and minimize itchiness, or may require topical or systemic immunosuppressive therapies to dampen the immune response. UV phototherapy can also be an option to induce DNA damage in the keratinocytes and halt their proliferation. New research has been targeting stress management, dietary intervention, and other immunotherapies to decrease whole-body inflammation. For some individuals, there can be significant feelings of depression or anxiety, especially when there are areas of skin affected by severe psoriasis. Psychological counseling can help sufferers cope with their condition. In fact, there's a field called psychodermatology, which utilizes strategies like anti-anxiety medications, biofeedback, allergy and immune function testing, as well as cognitive behavioral therapy. Okay, so to recap. Psoriasis is an autoimmune disease that leads to chronic changes in the epidermis due to overstimulation of immune cells and excessive proliferation of keratinocytes that don't mature correctly. Psoriasis most commonly causes silvery scaling of the skin and itchiness. The diagnosis can be made visually or with a tissue biopsy. There are various oral and topical treatments available, as well as new areas of lifestyle and dietary intervention, and psychodermatology, which addresses the relationship between emotions and physical changes in the skin.